And if it doesn't, it doesn't. So what we're going to do today, as I said, it probably will not go till 5. But I'm going to do the basics of medical imaging, physics, and radiation biology. Then we'll do breast. Then we'll take a break. Then we'll do neuro, and then we'll be done. Let me talk a little bit about the exam, since I know you guys are all freaking out about it. I haven't made it yet. Here's what I'm not going to do. I'm not going to try to find some esoteric bullshit in the text that where, you know, if it's like answer a question that was based on a caption of an image, you know. I mean, I think what I'm trying to do is identify the major themes that I want you guys to be able to understand. And if I show images, it will be based on the major themes. I won't be pointing to some nonsensical thing that you're not really expected to be able to know what it is. I'm just trying to get you to understand some of the basic concepts. So that's really the way the exam is going to be written. I will tell you this. I won't put any image on the exam that isn't either in the slides or in the text. Okay. So I'm not going to find you some image off of some obscure website or a case I read last night. Thank you. So there's that. Yeah. So I'm not going to do any of that. I suppose there will be multiple choice. Okay.
I don't know if there's a power button.
So I don't expect there'll be multiple choice. There might be, you know, 4 choices, and then E, B will, you know, C will be A and B. And I never wrote an exam before, to be perfectly honest, but I have taken several. So I definitely know what I hated about them and what I, you know, kind of liked about them, and I really expect it. I think you're going to find that this one will not be as, yes, ma'am.
I'm sorry, I didn't hear if you said, is it all images?
No, it will not be all images. Probably because if I put all images on them and then they had to reproduce them. You take them on paper or do you take them on the computer? Oh, that's good. So there's no mimeograph sheets. You don't get this. That was 1960s people. Okay, so all right, let's see. What do we get? Oh, look. Okay.
That's doctor's personal ones. I have to return it.
I am not. It's small enough to fit in my pocket, but what would I do? So, yes, sir.
Dr. Montecalvo, so is it going to be mainly based on your slides, or it also going to cover the book material?
There may be, if I take anything that's out of the book, it's going to be based on like a major theme, okay? So what I'm not going to be looking for is some kind of like the 5th choice of some list, you know, that's in a book in a table somewhere. If there's a list on the slides, you can be pretty assured that it's important enough that I put it on the slides.
Okay.
You know, I mean, the way I put these talks together was basically I used a template from a guy who gave this lecture 4 years ago. Okay, and then every time I get it, I basically start threading in more stuff of my own. Okay, so I mean, these slides are pretty much my own, even though I stole half of them from other people. They're still the stuff so if I'm putting it in here, you know, it's pretty important. If I take anything out of the text, it's really just going to be as something that goes along with what I've been saying. Okay. Yes, sir.
How many questions is it going to be?
They tell me 50.
And then now we're going to get like an hour or 70 minutes.
I have no idea. I don't know. It's up to them.
Fair enough.
Yeah. Yeah. Yes, ma'am. That was your question. Okay. Any others? I'm sure you'll think of more. Yes, sir.
Is there going to be like theory behind like the
Theory.
mechanisms of X-rays or mechanisms of like
Theory. I don't do theory. There will be no theory. This is all practical. This is going to be practical. What do I do when someone shows me an X-ray? What do I do when my orthopedist tells me to go look at the chest X-ray? And he expects me to tell him, as if an orthopedist would know how to read a chest X-ray. Now that's funny. But you know, what would you do if you were faced with, okay, I gotta make a decision about what this might be? how do I think about it? So the only theory is the theory of how your mind works when you have to make a decision. Okay? Okay. Keep firing. Good?
Yeah.
All right. So let's take a step back from all of that 4 hours of chest x-rays and hearts and lungs and alveoli and atelectasis and pneumonia and consolidation and air bronchograms and silhouette signs. And let's take a little jaunt into exactly how an x-ray image is made and why radiation is essentially not good for you, okay? Because these are things that, I mean, there's a tremendous amount of physics that goes into radiology. As a radiology resident, we had to pass a whole physics exam in order to be eligible to sit for the American Board of Radiology's exam. So there was physics up the wazoo for us. There will not be physics up the wazoo for you at all, but there will be some general comments about how we produce x-rays, why they do the things they do, and why they're dangerous for people, okay? So you're all familiar with the electromagnetic spectrum. You will recall that as the wavelength shortens, the energy of whatever it is that is causing that wavelength is increased, so that radio waves, which we're living with around here all the time, you know, swirling around our bodies all the time, are not particularly harmful because they are wide, they're a long wavelength, and they don't hurt anybody. Visible light is up in this, you know, in this area. You can see that my pointer is going to quit on me. That's all right. And then as we get further into the ultraviolet, the X-ray spectrum, the gamma ray spectrum, and then out here, we're talking about higher and higher energies as wavelengths get shorter and shorter. So clearly we are we're talking about stuff in this neighborhood, in the X-ray spectrum. There are even there are gamma emitters in nuclear medicine. We try to avoid them because they are extremely, relatively speaking, they're even more powerful than X-rays, and so we want to avoid, if we can, using them. So radiation is used in several, but not all, imaging modalities, okay? Now here's an important slide. Now here's something I think you should be very cautious of when you're studying, because I think it's useful to know what modalities are actually using ionizing radiation and which are not. So what are we talking about when we talk about ionizing radiation? Well, I mean, strictly speaking, a radio wave is radiation. Strictly speaking, light is radiation. But neither of those are of sufficient energy to actually cause a change in the atom, okay? So an ionizing radiation basically is something that is powerful enough to mess around with either the electrons of an atom, or even more powerful, mess around with the nucleus, okay, a proton, a neutron, or quark, or whatever. So the things that we're most concerned about with respect to radiation biology and radiology is the ionizing radiation. So radiography, anything from a chest x-ray to a bone x-ray to a CAT scan, or nuclear medicine, essentially uses ionizing radiation. So in radiography, it's X-ray photons of a particular energy. We'll talk a little bit about that in a bit. But something in the neighborhood of 35 to 150 kilovolt peak, kVp. Don't worry, I won't have to say that again. You won't have to know what it is. Okay? But these X-ray photons are in this rather narrow range of energies. And the reason why we like them is because we've been able to invent a detector, either film or digital, that can actually turn that image, take that X-ray information and make an image out of it. So we like something in the 35 to 150 kVp range. 35 kVp is something we use right around for mammography, because in mammography, A, you don't want to over-irradiate because the breast is a radiosensitive organ, and two, you don't need so much because the breast, when you squash it onto a plate and take a picture of it, There's not that much you have to go through, right? So you don't need that much energy. Now CT, on the other hand, also uses ionizing radiation, and also in the same general range between 50 and 150 kVp. But CT is a little different, and we don't need to go into it too dramatically right now. But if I'm standing and getting a chest X-ray, and the tube is over there, and somebody hits the tube and X-rays come flying at me, they're going to come flying at me, all of me, okay? And they're going to hit the film behind me, and they're going to make a picture. CAT scan is a little different in that when I lie in that tube, anyone here have ever had a CAT scan? Yeah. You lie in that tube, and you're basically being sliced very thin by an X-ray beam, like a razor, okay? And every time that tube goes around and as the table moves, you're basically getting sliced by a very high energy beam of X-rays. And in CT, you'll find the radiation dose is considerably higher than for a mammogram or for a chest X-ray, because the dose of radiation, the concentration of radiation is much higher. So we love CT. I love CT as much as I love my own life because it's so cool. But it is much more radiation dose to a patient. It must be used very cautiously, even though we don't use it cautiously at all. We order it for everything all the time. So the other modality that uses ionizing radiation is nuclear medicine. Nuclear medicine generally is where the patient gets to either ingest or be injected with the radiation so that the radiation is actually inside the body coming out. And you can imagine that if the radiation source is actually inside of you, spitting out radiation of anywhere from the low 100 kVp, kiloelectron volts when we talk about kVp, up into as much as 511 kiloelectron volts in PET imaging. This positron particle of 511 keV, which exists for a very, very brief instant in your body when you're getting a PET scan. That's some high energy stuff right there, and that can really cause some significant biological damage. So all three of these, nuclear medicine, CT, and radiography, use ionizing radiation. And so all of them must be used with some caution, with at least a thought given to what am I doing to the patient? What am I doing to the people around the patient in the case of nuclear medicine where you're actually giving somebody a dose of something? Iodine 131, you give me a tablet of iodine 131 and you say, I need you to treat your thyroid cancer with this iodine 131. It's very powerful. So I take the iodine, it goes to my thyroid gland, and it just pumps away radiation at the thyroid and all the surrounding tissues. And anybody who's within 5 feet of my thyroid is also going to get radiated. So actually, when we treat people with I-131, we instruct them, you need to stay away from your loved ones. If you're lactating and if you're breastfeeding, you need to pump that off for 48 hours. You need to get rid of that because that's radiated, okay? And so we need to be very cautious about this. And to be perfectly frank, there are very few physicians who give any real thought to this stuff, except for radiologists and radiation oncologists, because this is what we do every day. So there will be times when you'll have it in your mind and you might think to ask, and it's okay to ask because that's what we're supposed to do. We're supposed to know, to tell you what to do with respect to this radiation stuff. So the two major modalities that do not use ionizing radiation are ultrasound and MRI. And so they are favored for a number of things, specifically because they don't use radiation. I mean, ultrasound is ubiquitously used in evaluating the fetus. No radiation. No real significant danger to the fetus to use ultrasound at any point during the stages of conception and during the stages of pregnancy. There have been some, you can crank up the power on an ultrasound machine, especially if you're using power Doppler or some other things that can actually raise the temperature of an amniotic sac a little bit. But there has never really been any proof of any kind that ultrasound is harmful to the fetus or to any other tissue. And then MRI uses radio frequency waves in the radio spectrum, okay, so not very energetic, not enough to ionize any atoms, uses them in a very complex dance with the magnetic field to cause hydrogen protons to flip on their sides and then do all kinds of other things, which I'll talk about a little bit in another lecture, but no ionizing radiation. So the three ionizing radiation modalities, radiography, CT, and nuclear medicine, and the two non-ionizing radiation, ultrasound and MRI. So how do we actually make an X-ray? And it's actually, I mean, it's actually now an ancient technique. Anyone know when the first X-ray was actually created and identified for what it was? 1895. William Conrad Röntgen from somewhere in Germany, who by complete ridiculous accident had some film laying around, and he had some X-ray source laying around, and put his hand on it or something, and looked at the film, and his finger, it was a bone. He's like, "What was this?" So, I mean, and amazingly, it was done in like 1895, and within 10 years, medical X-rays were being used very, very commonly, or relatively commonly. I mean, it was obviously the big thing. And so for the longest time, so there was a tremendous impetus to figure out how to make medical X-rays regularly and consistently. How do we actually do this so that we actually can take this natural phenomenon that he figured out and turn it into something useful? So what every X-ray machine has is a tube. And this is a schematic of the tube. This is a real tube. When I was a resident, we were replacing one of the fluoro units in my hospital. And I went to my chief and I said, "I want the tube. What can I do to get the tube?" And he said, "Well, if you can figure out how to get it out of here, you can have it." So I had to basically break down the machine. And the tube is this glass thing, and it's very pretty, and I have it in my office. But it's actually surrounded by machine oil in a huge steel case, because when this thing gets going, it gets really hot, and it needs to be cool. So how is it exactly that we create the beam? What we're doing, essentially, is we are taking a charged particle, we are creating a vacuum inside the tube, we're creating charged particles, and this is basically like a little heating element, okay, that the small charge goes across. And the heating element heats up, and it basically creates electrons, negatively charged particles. So we've got this evacuated container tube, this evacuated glass tube, and a very significant voltage from one side of the tube to the other. So this side is positive, this is the anode, okay? And the anode is spinning, and it's particularly designed so that when you create the electrons off of this heating element, and you've got this major potential, and this is positive and the electrons are negative, the electrons go flying this way toward the anode, which is spinning. The anode is made of, depending on what energy of X-rays you want to create. The anode can be made most commonly of tungsten, which is the element for most radiography. Now for mammography, because we want to create X-rays of a slightly different energy, we use molybdenum for the anode, okay? So the electrons go flying and hits the tungsten. And when the electron hits the tungsten, there is an atomic action that occurs, which I'll show you in the next slide. And X-rays come pouring out of this tube, okay? Now the X-ray beam comes out of the tube, and it can actually be what we call collimated, or it can be steered, okay? And it can be steered basically toward the target. So here's, here's an X-ray tube. This is the cathode. This is where the electrons get started. This is the anode. This thing is spinning. There's an there's a vacuum in the glass. Turn the thing on, the electrons hit the tungsten, the X-rays come out. And it gets very hot. Even when you're just doing it like for a little bit of time. With fluoroscopy, when you're actually standing there and the tube is active, X-rays are being produced all the time, the thing gets really hot. So it has to be encased in all that machine oil and steel and stuff. Any questions about just the physics, actually how X-rays are physically made? So what happens inside the tungsten or the molybdenum to actually cause an X-ray to be made? There are two kinds of X-rays formed. Okay, one is called characteristic radiation, and it's called characteristic because it's characteristic of a specific element that is being bombarded with the electrons. So the characteristic spectrum of a tungsten energies that are the X-ray energies that are coming out of tungsten would be different than the X-ray energies that are coming out of molybdenum or something else. And then the other kind is called Bremsstrahlung or breaking radiation. I'm probably not going to come after you on this stuff, but it's just kind of interesting. So okay. So what happens here's the electron coming crashing into that tungsten atom, and what it does is it hits one of those electrons in the inner shell, and it kicks it out. Okay, it's ionizing the tungsten atom. This is the act of ionization right here. Boom! It hits the electron. This electron hits this electron, and like in billiards, it kicks it out. Well, when it kicks it out, it leaves a hole in the inner shell. And if you will remember your atomic physics, if you leave a hole in the inner shell, something is going to fill it. Okay, it's going to be an electron from the outer shell that's going to be promoted toward the nucleus. And when that electron gets promoted, X-ray energy is released. Okay, so that's actually, it's like a ping pong thing, and then the X-ray is created. Now, because of the energies of these electrons in this tungsten atom are essentially fixed because of quantum physics, every time an outer shell electron is promoted, it's always going to release the same X-ray energy, an X-ray of the same energy every time, because it's unique to tungsten, right? It would be unique to molybdenum or unique to something else. So that's characteristic radiation. Breaking radiation or Bremsstrahlung is actually makes up more of the entire number of X-ray photons. What happens is that here's an electron flying, but it doesn't hit the atom. It actually gets near the nucleus, near enough. It doesn't hit anything, but it actually is deflected because of the properties of the nucleus itself. The electron is deflected, and when it's deflected, it slows down. And when it slows down, there's a conservation of energy. The energy that is released when the electron slows down has to be turned into something. It's turned into an X-ray, and that's the breaking radiation concept of. So there's two kinds of radiation: characteristic and breaking. So the spectrum of call it a tungsten created X-ray would be, here's all the energies that are being created. If you were to graph them, you'd get this graph, and then you'd get these two peaks, and these are the peaks of the characteristic radiation for tungsten. Okay, one of those peaks is probably at about 140 kV, which is a very common X-ray peak that we use in radiography. So for molybdenum, this would look something different. The peaks would be closer to 35. That's enough of that. Any questions about that? Okay, so we've created the X-ray. We got a patient. How is it that we actually turn that X-ray? How do we take that X-ray energy and turn it into an image? So the X-rays are going to pass through us. depending on what they encounter, they may go straight through and encounter nothing. They may hit something and be deflected, or they may be absorbed completely, like hits the X-ray photon hits the dense bone and doesn't get deflected, doesn't do anything, it's gone. So what happens is these X-rays are coming through, and the first thing they encounter is a grid. So that basically this grid channels the X-ray energy. And it will, when something gets scattered, if this photon got scattered, this X-ray got scattered, then even though the thing that I'm looking for is here in the patient, if it gets scattered and if it gets red as if it were over here. And so I wouldn't get very good anatomic detail, right? If I was reading all of the scattered X-rays, I don't want to see scattered X-rays. Either the thing gets absorbed or it gets through. Now when it gets through, it'll get through, but it might get through with lesser energy, right? So something that went right through my lung, which is just air, would hit the screen, would get to the grid with more energy than something that, say, that went through my heart, which, because it's more soft tissue, might actually slow down or decrease the energy of that X-ray photon when it gets to the grid. So what you've got getting through the grid then is X-rays that are essentially telling you where in space the thing is in the body, but it's also telling you, because their energies are now somewhat different, how thick or how thin or how easily or how more difficult it was for that X-ray to get through the body. Okay. So the grid basically is there to keep everything anatomically correct and to defeat any scattered X-rays. The next thing that these X-ray photons encounter is an intensifying screen. So here's a common misnomer, is that people will think, well, I had an X-ray. So those X-rays were immediately turned into an image. Actually, the X-rays don't contribute anything to the image. The only thing they contribute is that they hit this intensifying screen, and the intensifying screen creates a little blip of light. So an X-ray that came flying straight through me with nothing would hit this intensifying screen, and it would cause a little burst of light. Now, something that went through my heart, which had lesser energy by the time it got to the fluorescent screen, would also produce a little burst of light, but it would be less bright. Okay? And it's all these little bursts of light that actually hit the film, just like when you open a camera lens, you take a picture, you've got light of different intensities hitting the film. Now you've got light of different intensities hitting the X-ray film. And it's that we take, that X-ray film, or if it's a digital detector, we take there's a latent image that is now created on the film or on the digital detector. And so then in old days, you would take that film, you would run it through a chemical processor, and then you would have, just like you would do, remember, you guys do remember probably, film and a camera. You would take film to, Walgreens, and they would turn it into a picture for you. Same thing happened with X-ray film, is that the tech would go into a dark room, they would open this cassette that had the grid and the intensifying screens on it, and they would take the film out, they'd put it through the processor, and out the other end would drop the film with the image on it, which was created by the light, which was created by the X-ray that went through the grid and went through the patient. So what we do now is we don't have film. We have these digital detectors that also are being interacted with light, not with the X-ray. So the X-ray hits a screen, the screen creates the light hits the digital detector feeds the computer, which turns it into an image. So it's a little complicated, but the thing I want you to get out of here is that it's light, not an X-ray, that actually causes the image to be made, and that there's a latent image that is created on the film, that is turned into a real image, either through chemical processing if it's film, or computer stuff if it's a digital image. Any questions about this? Okay, so now that we have created a picture, we've also irradiated a patient. And this whole idea of using ionizing radiation, I want to kind of dig into a little bit here, because it is unlikely that in the rest of your careers in medicine, anyone will ever tell you this stuff, because nobody really cares, except radiologists. And we probably care a little too much. The only reason we care too much is because it's the only thing that distinguishes us from all those other doctors, right? And they're also important, and they're taking care of patients, and it's also wonderful for them. But we know something that they don't. It's about radiation biology and radiation physics. So, not that they care, because they don't. So we all, you know, by virtue of living in this universe, are surrounded by natural radiation all the time. If any of you grew up in certain parts of this country and had a basement, you were probably being subjected to radon exposure all the time. Radon is a naturally occurring byproduct of the disintegration of certain naturally uranium and other things that are in the earth. Just by the nature of being on the surface of the earth, you're getting bombarded by cosmic rays all the time. Cosmic rays are a not insignificant source of radiation. When tomorrow I get in a plane and I fly to Las Cruces, New Mexico, don't ask why, I don't know myself. But when I go to Las Cruces, New Mexico tomorrow and travel at 35,000 feet, I will be subject to considerably more cosmic rays than you will be here on the surface. So there's always background radiation, and we're always subject to it. So one of the things that we try to do is when patients wonder, and when I try to teach about radiation biology, I really try to do it, and I explain to patients about your relative risk of this radiation source, this ionizing radiation that you're about to receive on this test, relative to the natural background radiation. And I mean, we know that radiation, ionizing radiation, is damaging to living cells. And so whenever we write a prescription for an X-ray or think about what imaging test to do, we should always remember in our minds that this is like prescribing a drug. It's like when I was a medical student and wanted to give somebody oxygen, I had to be reminded oxygen is a drug. It should be, you have to write an order for it. That's why you have to write an order for an X-ray test, among others, is that radiation is like a drug, and it has to be carefully managed. So if you were to try to weigh what is my radiation dose relative to natural background radiation for a number of different kinds of studies, this is a nice way to look at it. This chart talks about dosing what's called millisieverts, MSV. Don't worry about it. I'm not going to ask you about millisieverts. There are several different units that people talk about radiation dose in. This tends to be the most common one now. But take a look here. If you were to have an X-ray of your chest, you would be exposed to about 1/10 of 1 millisievert of radiation, which would be the equivalent of 10 days of just walking around Earth. Okay, so that's a pretty small dose. Mammography is going to be even less. Actually, it says it's more. But the thing that, like, I had a dental procedure yesterday, and I had some X-rays. Infinitesimally small dose. Okay, essentially 1 day's worth of dose. But look at CT. CT, just a regular CT of the chest, 7 millisieverts, which is essentially 2 years worth of background radiation dose. Okay. Now, I can tell you that a PET scan, which is often done in conjunction with a CT, PET CT are often done together. That's some serious dose there, really big. Now, should that mean that nobody should ever get a PET CT or no one should ever get a CT? Well, no, because even though we know that the risk of a radiation-induced disease like leukemia or cancer, there's no threshold, okay? So you can get one X-ray photon hit you or one cosmic ray hit you, and your risk of getting the cancer in 4 years or 10 years or 20 years has gone from 0 to not 0, even with one exposure. So there is no threshold with radiation. However, the likelihood is extremely small. And I'll talk a little bit about that in a couple of seconds. But let's talk about, yes, sir.
Just for truth's sake, one of the doctors I worked with told me that a single CT-AP was equivalent to the background radiation of one transatlantic flight. So we always tell patients, was that accurate?
And that's exactly right. He's right.
Accurate?
Yeah. I mean, I'm flying way too much now because I should be glowing. Because of the work I do now, it's a lot of travel. But that's true. In fact, I would say the same thing. A pregnant woman would come and say, should I get this, this study? And it's really something that we do instinctively, and I would like you to start thinking about too. You get a woman who's in the ER and who was 12 weeks pregnant and has right lower quadrant pain. You have to ask yourself, what is she might have an appendicitis. What if I can't diagnose this or don't diagnose it or do some other test that isn't as sensitive? So there's a risk benefit, right? The risk is the radiation dose. The benefit is finding the appendicitis and fixing it so that she doesn't, have a real problem. And I would say the same thing to a patient like that. I would say, look, the risk is not 0. It is never 0. However, you'll receive the same amount of radiation as if you were in a plane flying to London, okay, or something like that. And that we also know that even though the risk is not 0, it is very, very small for one CT scan to be linked specifically to a cancer that happens 20 years from now. In fact, we have no way of being able to do that. It's impossible for you to say that the CT scan I had in 1998 caused my cancer that I got tomorrow. You can't do it. But we know that based on population studies from Hiroshima and Nagasaki, that we know that as a population, that there will be X number of cancers more based on the dose that was received. So
Is the risk higher for a fetus?
the risk is higher for a fetus, yeah. And so we have to be especially cautious about that, certainly.
If you have a fluoroscopy for any amount of time, it's like a 1-to-1 ratio of how much more radiation is exposed?
Actually, it probably isn't. But the thing about fluoroscopy in specific is that, and I actually don't have a slide of that here, but next year I will show you, is that you can get radiation burns from fluoroscopy. I mean, the early radiologists, I'm talking about in the early 20th century, these guys lost fingers and hands because what they would do is these old fluoroscopy machines that would be on all the time, and they didn't know what the radiation risks were. Their hands were in the field all the time. They were moving. The guys were losing fingers, radiation necrosis of the hands, and the patients would get radiation burns on their backs or on their abdomens. Even today, some cardiologists are very, very, how should we say, aggressive when they use fluoroscopy during cardiac catheterization or other invasive procedures that they do, because they aren't really mindful about radiation biology. And I've seen half a dozen cases in my career of radiation burns induced by a cardiologist that was just standing on the pedal, just bombarding the patient with radiation for minutes and minutes and minutes and minutes and never got off the pedal. I mean, that's bad. It's bad. Of course, and and there's yes. fetuses, children are definitely more radiosensitive than adults for a number of reasons. But you know, the fetus, its organogenesis, you know, we're talking about anytime you've got highly, very fast replicating cells anywhere. So in a fetus, everything is replicating like crazy, growing like mad. In a kid, all those growth plates, you know, the organs are growing much faster than all of us in this room, which pretty much are full grown, are done, right? So we're at that homeostasis, but the kids and the fetuses, their metabolic rate, their cell turnover is so much faster, so much higher. So what is it exactly that we're concerned about with this radiation dose? Well, we're obviously most concerned about what happens to the DNA molecule, okay? Because it's where most of the damage is going to occur. We really don't care so much about what an X-ray photon does to, you know, does to other parts of the cell. But the DNA is what's most important because of the risk of genetic mutation. So there's two effects that we want to concern ourselves with when it comes to radiation and DNA. One is the direct effect, which is what happens when an X-ray photon or radiation hits the DNA directly, okay? And it causes some screw up in the DNA molecule, which causes a repair, which might not repair properly, and you get a mutation or something like that. And then there's the more common indirect effect, which is when the DNA is not really struck directly by the X-ray photon, but is actually, what happens is the X-ray photon ionizes a water molecule. And then the water molecule creates all these free radicals, and then it's the free radicals that bond with the DNA and cause damage to the DNA. So two effects with radiation with respect to DNA, direct and indirect. This is the more common one, the indirect effect, but they're both potentially damaging to DNA. So we can't help it. We're gonna radiate people, and people are going to get cellular effects from radiation. So there are four basic things that are going to happen. Either nothing is going to happen, where the cell is undamaged. There's an injury, a sublethal injury to the cell, but the damage is correctly repaired. No harm, no foul, everybody's good. There's a mutation in the DNA, in case the cell injury or the DNA damage is incorrectly repaired. And that may or may not cause any problem. You know, of course, it's probably because we just don't understand it all yet, but there's just a lot of silent DNA in people. You know, not every base pair is a gene that is causing something to happen. So there may be a mutation in a silent area, nothing that happens, or there may be a mutation in an area that causes, you know, a cancer. Or ultimately, the cell could be just essentially killed by the radiation. And as we get higher and higher in dose, you know, these are the things that we are most concerned about with nuclear accidents, atomic war, that kind of stuff. What are the kinds of cells? This goes to what I was just talking about. The cells, there are certain types of cells that are much more radiosensitive than others. Anything that has any cellular line that has a very high reproductive rate that is constantly turning over. There's a reason why people who get radiation therapy, in part, or chemotherapy, which are both basically targeted at fast replicating cancer cells, it's the reason why they lose their hair. They lose their hair because hair, not that I have any, is very fast replicating cells. And the chemo hits those quickly dividing hair cells, kills them, because it's designed to kill fastly, you know, quickly metabolic, you know, high metabolic rate cells. Similarly, any cell line that has not differentiated yet into its final form, as in the early stages of a fetus in an embryo, the most radiosensitive period is basically in the first trimester of pregnancy. I generally, if a woman in the third trimester comes and she wants to talk about the radiation risk to her fetus, I basically tell her the risk is over. Okay. Yes, your fetus is still your fetus is still growing, but you're 34 weeks, and essentially all of the really important stuff is already done. Okay. And that same woman comes in at 10 weeks, knows she's pregnant, 10 weeks. I'm very reluctant to do anything radiation-wise with that patient. It's wait. Let me see if I can do it with ultrasound. I mean, we do MRI now for rule out appendicitis in women who are 10 weeks pregnant. They're not easy to read because there's a lot of stuff going on in there, but it's better than radiating somebody. So you got to be really cautious about when. These are the kinds of cells that I think you want to be cautious with, right? Any of the blood cells, any of the germline cells, skin and mucosa. When people who are exposed to those huge doses of radiation, either from atomic fallout or Chernobyl or whatever, the people that died when they died quickly. They died of their whole GI tract sloughed off, basically. All the mucosa in their GI tract sloughed off because these are high turnover cells. They get whacked with 6,000 millisieverts of radiation, and everything stops. All this, there's just cell death all over the place, and they wind up essentially dying of GI issues, and not a pleasant way to die. So the effects of the ionizing radiation are the acute somatic effects, which is the immediate effects to the organism who is receiving the dose. Okay, that would be the guy who was standing in Chernobyl when the thing went boom, and he's done. He was unprotected, and he's not going to survive. There's the delayed somatic effects, like the people who might have been 20 miles from downtown Hiroshima in 1945. They didn't die from the blast. They didn't die from the immediate humongous radiation dose that they got. But they're the people that might be getting leukemia 3 or 4 years down the road, or a solid organ tumor, 10 years down the road from the ionizing radiation. And then there's the genetic effects, which were predicted and we observed in those patients who maybe were 50 miles away from Hiroshima and had certain genetic effects, so that their offspring had a problem, some kind of genetic defect. So these are the kind of acute somatic effects that I wanted to just review just very briefly. I mean, these are the kinds of things we're talking about. So we said that the chest X-ray was 1/10 of 1 millisievert. Okay, so if you took 10 times 100, 1,000 times the dose of a chest X-ray, and just blast me with 1,000 times dose chest X-ray right now, likely that there would be no detectable effect. Okay, but now if you're talking about maybe 100,000 to 1,000,000 times a chest X-ray dose, now you can expect that red cells and white cells would be affected. You become neutropenic, you become leukopenic, right? And you might not be able to fight off infection. As you get your dose up higher, you're going to start affecting that GI tract, the nausea, the vomiting. Your ability to fight infection goes way down. 3,000 to 6,000 millisieverts. Okay, now you're talking about a lot of stuff that's going really bad. Internal hemorrhage, diarrhea, inability to fight infection, sterility. At 4,500 millisieverts, half the population will die. And at 6,000 and over that, I mean, you're done. Yeah.
So do we know approximately what was the effect in Fukushima, for example? And
Fukushima.
yeah,
I don't think we know for sure because it hasn't been enough time. It's only been 4 years. I mean, the only reason we know about Hiroshima and Nagasaki was because those studies they went on for 20 and 30 years. I mean, immediately after those bombs were dropped, the U.S. was in their study, and because they knew they had to. And when I was a radiology resident in the 80s, and we were doing this stuff, it was all Hiroshima and Nagasaki longitudinal studies that had been going on for not the 80s, so it had been 40 years of studies. So I don't think we know yet. I mean, we know what to expect, and I'm sure there are plenty of hypotheses. They know what the doses were in the general area, so they're probably out there, folks out there saying we expect this increase in the number of solid tumors. We expect this increase in the percentage of leukemias and lymphomas. So, yeah, and it's just a matter now of seeing if the hypothesis can be proven by observation. There's nothing you can do. Okay, so as I said, we know that radiation is a known carcinogen. We know that there is no threshold. There is no threshold for the effect of radiation on the risk of a cancer occurring. We just can't say who's the guy or gal that's going to get it, and we can't say necessarily. We can guess at how many or what percentage are going to get it, but we can't say who. Medicine is a funny thing. You can say, well, here's this patient. This patient has a very rare disease. Almost nobody gets this disease, but from the patient's standpoint, disease has a prevalence of 100%. They got it. So you have to be very cautious whenever you speak to patients about things that are rare. It's almost like, well, we have no idea how you got this, but it's going to happen to somebody. And when it happens to you, it's 100%. So you never want to be too flippant or dismissive of that with patients, because they get it. When they got the disease, they don't get a damn. They don't get a damn that it's 1 in a million. It's 1 in 1. So always be careful of that. As I said, radiation does not produce cancer in every person. There is a latency period for leukemias. Blood tumors, blood cancers tend to come on a little faster than solid organ tumors or solid tumors. There's essentially a linear relationship between dose and risk, but again, we don't know exactly who's going to get it. And on the order of, for a 1 millisievert, which would that be, 10 times a chest X-ray dose, a solid tumor cancer risk is maybe increased by 1 in 10,000, and a leukemia risk maybe 1 in 100,000. But so this gets very statistical very quickly, and I'm not a statistical person. So just understand, the major take-home thing here is that radiation is a drug. You got to be thoughtful when you order something, and you've got to be prepared to either answer a patient's question on the relative risks or find a radiologist who will. Okay, because you will be asked. I guarantee you will be asked when you are in a pediatric clinic and you tell a mom that we want the baby to get a chest X-ray, we want the baby to get a belly film, or feel a mass in the baby's abdomen. Boy, that's never a good thing. CT scan. That mom is going to ask you, among other things, what is the risk with respect to the radiation? Honestly, I don't think you really necessarily feel like you should be prepared to give her the whole story, but you should be prepared to set the stage and make sure the radiologist knows to give her the story. Just put it in the note. Mom will be asking about radiation risk. We're used to it, but it's always good to know. So here's the fetus during the organogenesis phase, definitely the most risk to a fetus, because all this stuff in here is just cranking away, and half of these cells are still not completely differentiated yet. So they still don't know what they're going to be yet. They don't know if they're going to be neural tissue or gut tissue or whatever. So always be very cautious with pregnant. That's why we always ask patients in radiology. We always want to know if the patient is pregnant before we do anything. It's almost, I mean, universally, women are gonna be asked. I mean, and, you know, as far as I'm concerned, anybody of childbearing age from age 12 up is pregnant until either they tell me they're not, or I can prove they're not by chemical means. So, you know, I don't wanna be, I hate to be in the position of knowing that I just radiated a patient who turned out to be pregnant and I didn't know. Sometimes they don't know, you know, and that's okay. But somebody's got to say, hang on, let's just, here, pee in a cup, or, you know, let's figure it out before we do anything more.
So if you were presented with a female patient that you wanted to know, would you like order a
Yeah.
pregnancy test?
Actually, I'm a doctor, I can do that.
Yeah.
Yeah. No, I would. Generally, they're coming from the ER. So I would basically pick up the phone and say, dudes, what is the pregnancy status? We don't know. Is it out? Is it coming back? We don't have it yet. We sent it out. Okay, I'll wait. Just gonna wait. Just wanna know.
So you honestly ask that for every patient with pregnancy age that's not maternal?
Oh, the tech will ask me. I mean, I don't, but the techs are trained to do it. That's, you know, any chance you're pregnant. Yeah, if they say no, okay, I'm gonna take them at your word. If they said no. They would have a better reason to know than I would, but, let's take, okay, last slide in this set. I love this slide because it is emblematic of just how crazy we've become with medical imaging. Trust me, I'm very happy about it. You know, I make my living doing it, but 1980 in blue compared to 2006, the number of CT scans in millions that were done, okay, in the United States. The number of nuclear medicine studies were done, more than triple. The number of CT scans probably went up by 4 or 5 times. And here's the total population dose from medical imaging, from medical radiation. You know, I don't even know what the units are, but it's obviously like 8 times. We are now radiating people at 8 times the rate for medical imaging than we did 30 years ago. And that's a lot. And that's probably not getting any less. More and more people have access to healthcare. More and more people have access to medical imaging. Medical imaging is now completely ubiquitous. In 1980, commercial CT scanners had only been available for about 5 years, so there weren't all that many of them. Now there's one in every corner. You know, we just radiate the hell out of people. I mean, you will see, as I have, I mean, I read these cases, I read these CT scans all day and all night, and I will see patients who are 20 and 30 years old who've had 15 and 20 CAT scans. Okay, I mean, look, okay, either they're sick, or they like going to an ER, or they're looking for drugs, or I don't know what. But you come into the ER with belly pain at 2 o'clock in the morning, you are getting a CAT scan. Because there aren't enough people to examine you, take care of you, hold on to you, hold your hand, tell you you're okay. You're getting a CAT scan that is being ordered by the PA or the nurse practitioner, you know? And I'm not saying that you guys shouldn't be ordering them. I'm just saying that when you see a patient that's been in 6 times and has 6 CAT scans in 2 years, at least say to yourself, what the hell are we doing here?
Do all imaging studies come back with an interpretation of the radiologist, or just order that?
No, you order it, you're gonna get an interpretation, every single one.
Do you think that some of like the increase also has to do with patients coming in and wanting scans? Because I know some doctors,
Absolutely.
like, they get patients that won't, if they leave the office and don't get their scans,
No,
they'll go
absolutely.
somewhere else to get it.
But you're absolutely right. Now, imagine you're a busy clinician, you got an office full of people, and you got a patient who's adamant that they want a scan, any scan, radiation or not, MR, ultrasound, doesn't matter. What are you going to do? You're going to try to reason with that person while people are waiting and you're trying to make a living and the phones are ringing, or are you just going to go, okay, I'll just write the script, yeah, you know? I mean, honestly, there is no reasoning with some of these folks. There isn't. My wife is a rheumatologist, so she sees a lot of patients in chronic pain all the time, arthritis, you know, and she's just like, she'll be like, there's nothing I can do. They insist on, completely apart from the people that come in who read, the newspaper that morning and there was something about some new drug that they want. I want this drug right now. It's not even available yet. It's not even, we don't even know that it works. I want a scan. I want this. I want that. This is why I went into radiology, people, because I don't have to deal with that stuff. Okay? You will. I don't.